Morning everybody, and welcome to this morning's Adults and Community Wellbeing Scrutiny Committee. Before we begin, there is no fire drill planned this morning, so in event of a fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, assemble in the car park at the front of the building and wait further instructions. I would like to welcome Kellum Cook. Welcome, Kellum, our new Vice Chairman for this meeting and for the committee, so welcome. Also Councillor Wendy Bowkett, nice to see you here, and Colin Matthews as well, and Martin Samuels, our Executive Director of Adult Care and Community Wellbeing, and we've also got Justin Hackney and Pam Clipson to join us along the way. Okay, we'll start off, well, I suppose also we'll welcome Thomas, who's taken over from Emily, so welcome Thomas. So we'll start with apologies, please, Thomas.
Thank you, Chairman. We have apologies from Councillors Karen Lee, Mrs Nicola Clark and Trevor Young today.
Brilliant, thank you. Declarations and members' interests. If any members find an interest along the way that hasn't been already noted, let us know. Minutes, we'll go to the minutes of the 24th of April 2024 to confirm as a correct record the minutes of the meeting found on pages 5 to 10. Are we all happy, and can I have a proposer and a seconder? Propose Rob Kendrick, second Mark Whittington. All those in favour? Excellent, thank you. Any abstention? Yeah, not there. Thank you. Announcements. I've got no announcements, and Martin? No. So all quiet while in the election process. So we'll move on then to the first, in effect, item, which is the financial position. So adult care and community wellbeing's financial position. So I welcome Pam Clipson, Head of Finance, to just give a summary, and we'll go from there.
Thank you. Morning, everybody. So report obviously is in the pack. In the context of the increasing demand and the inflationary pressures that we talked about as we set the budget for 23-24, it is really pleasing and a sign of the level of financial control that we've got within adult care and community wellbeing to be able to confirm a year-end position of just £70,000 overspent on what is a gross £300 million budget for the year for the Directorate. So a really healthy position, particularly when you look across other local authorities for their adult care and community wellbeing areas. There are pressures that are detailed in the report, particularly on page 12. We have seen an increase in our adult frailty and long-term conditions area in the number of previous self-funders that are approaching the local authority for support. And you can see the increase forecast there that we've seen. We have factored that level of increase into our 24-25 budget. So as we monitored that throughout the year, we did build that anticipated impact on 24-25 within our budget setting process. That will be an area of high risk that we'll continue to monitor throughout 24-5 to see how those look going forward. We've also had impact in our specialist adult services area from the Worcestershire ruling. Which for those who may not be aware of that, that's the challenge from our section 117 aftercare, and that ruling confirms the local authority where a person was already ordinarily resident when sections should incur those costs. And we received one of those cases in February 2024, which they can backdate, was backdated to 2019, and that has a cost of £454,000. That is not a cost that is in our control. That is as a result now of that new ruling. Because it was and came about in the latter part of 23-24, That was after we've set the budget, so that is an area where the operational teams are working through to see if we have any more risk exposure to that. If there is any further risk exposure, we haven't got any financial allocation for that one. We have been, the bottom line is supported by the maximisation of the public health grant. So you can see from the table on the first page, we continue to get an increase in our public health grant in 23-4, and that has enabled that underspend to support our adult social care costs. We have also received in 3-4 the continuation of the discharge fund, which has supported the increase in activity we have seen as a result of increased discharge. And we've put that predominantly to our active recovery service, which you've received papers on in the past on the outcome of that, and more towards our packages of care that have been required as people have been discharged from hospital promptly. Also on page 12, we have seen the continuation of the Market Sustainability and Improvement Fund, and we saw an increase in year of that funding for £5 million. That has, both of those, discharge and MSI, have continued into 24-25. So the work that we've done that has enabled our 4-tier home care rate, our 2-tier community supported living rate, and the increases that we made to support the workforce across adult social care has continued into 24-5. So again, no pressures coming off those actions that we've taken because those grants have continued. So all in all, a very positive financial position for 23-24. We are forecasting balance for 24-25, although I will caveat we're only on month 2. So an awful lot of time still to go through for 24-5. But we will keep the committee abreast of any changes as we go through 4-5. And that will be a lady called Gemma Hatton, who starts with us on Monday. Any questions? Happy to take. Thank you.
Okay, thank you. I've got Councillor Wendy Bowkett.
Thank you. I'd just like to thank Pam for her excellent work. It's not easy to keep a balanced budget in adult care. You know, we have our ups and downs, and bills come in and we have to be paid, but she's done an excellent job over the years, and I, for one, will be sorry to lose her because she has held us together. She's been our glue in adult care. So thank you for all your hard work, and you know, the figures here just goes to show, you know, that what good work you are doing, and the team. It's not, you know, we have a team behind you, obviously, but yeah, it's a really good budget, and thank you very much, and please come back soon.
Thank you. Mark?
Yeah, I mean, I think I'd like to sort of just echo the comments that Councillor Bowkett just made. I mean, we know this is, you know, the adult social care is the biggest single element of our expenditure, and in terms of the sheer size of the budget to just come in, I mean, 70,000 overspent, I mean, in percentage terms is minute, and I think it's a great testament, you know, to everybody in the team. And also the level of financial planning that goes on, and I know because I've seen the financial model that they actually use, you know, and it's proved time and time again, year on year, that it works. You know, so no real questions other than a great huge thank you, and it makes an accountant's heart happy to see such a big budget coming in. Well, as I say, to all intents and purposes, breaking even is fantastic.
Thank you. Callum?
Thank you, Chairman. I think I echo the comments that have already been made in terms of the finances. You know, it is incredibly difficult in adult, you know, social care and in terms of funding. I suppose if we were looking at the year ahead, and I know we're obviously only 2 months in, do you see any sort of significant challenges that might impact on our sort of financial record going forwards, or anything that you're predicting that might happen over the next 12 months?
Yeah, yes. I mean, we always have continuous challenges. The increasing demand across our services for mental health specialties in particular. We are continuing to forecast as pressures. We have got close workings, obviously, through the Directorate Leadership Team with plans in place. And maybe, Martin, if you want to pick up on some of those.
Yeah, thank you, if that's okay. So a couple of things I wanted to note. One is that, you know, Pam has already commented about the size of the budget. It's when you look at the numbers, it's a large budget from a net perspective. You know, a net budget of £185 million. Pam noted correctly that, of course, that we spend a significantly larger amount of money than that. That we note the income we get through the public health grant and through the Better Care Fund, which comes largely through the NHS. But of course, we also adult social care is a means-tested service, so there's also within that there's a significant amount of funding that we charge people for. So it's important to recognise here we are in effect a £300 million budget spend, and to come within £70,000 of that is, I think, as has been said, real credit to the team. And of course, I was only around for the last couple of months of that, so I can't take much of that credit at all. It was the team. I mean, you asked about pressures ahead. The classic pressures that we, along with everywhere else, are experiencing. The first is demography. We know there are more and more older people, and people are living to a much greater age, and they are living with many more health conditions. Now that's sometimes presented as being a bad thing. All these old people around. Well, for me, that's a sign of enormous success, that people are living to a ripe old age, and more people are living to a healthier old age than they were before. Nonetheless, we are seeing a rapid increase in the number of older people and of older people with long-term health conditions. That has a significant pressure on the adult social care system. In particular, we're seeing a particularly rapid increase in number of people over the age of 85. A very substantial proportion of people in that age cohort are in the social care system, and indeed a very significant proportion of them are in residential care. So the faster that particular cohort grows, we see a real pressure on our services, and Lincolnshire is seeing one of the fastest increases in the country. From that, we start from an older population on average than most of the country. We are seeing that population growing faster and ageing faster than just about anywhere in the country. We're also on the working age adult side, and again, it's a sign of massive success. That it used to be that, for example, someone who was born with Down syndrome, they probably lived through to their mid to late 20s, often not much longer than that. We now are seeing people with Down syndrome who are reaching retirement age. And again, that's a huge success, that people are able to live a long and fulfilled life, but it means they're with us for a much greater period of time, and therefore the implications in terms of the pressures on the budget. We're also seeing increases from the National Living Wage, and again, it's quite right that people who are providing care, which is, our system relies on people providing care, that they should be appropriately remunerated for that. But of course, that's a significant increase. The National Living Wage has been rising much faster than inflation to try to reach a reasonable level. But of course, we have to pay that, and I think the amount, each pound on the National Living Wage is several £1 million cost to the budget. So it's really important that we get that right. And then what we're also seeing is a general increase in acuity of the level of need that people have, and some of that is as a result of the challenges that the NHS is finding in catching up from the backlogs from COVID, that there are people who are waiting longer for treatment and are therefore in the community more unwell than they would have been, but also the success of the NHS, that people are living longer with more conditions. So I think those are sort of the key challenges that we're facing. So we're really having to focus on having a different way of working. We can't carry on working in the way that we really have been. So there are really sort of three aspects that I think I'd want to highlight to the committee about the ways we're changing. A real focus on prevention. We often say that the fastest hospital admission, the fastest hospital discharge is the admission that never happened. And in the same way, the best experience for someone of social care is if they never have experience of it at all, because they actually were able to live a life that kept them well and healthy and independent. And so we're really focusing on what I've recently been hearing. I have to say I really dislike the term prevention, because it's by definition a negative term. I've been hearing people recently talking about health creation, which feels a much more positive term. I'm not sure it's quite catch on, but the idea of making it easier for people to live a healthy life that allows them to retain good health and independence for much longer. We're also working to be much more person-centred and strength-based in our approaches. Rather than saying what's wrong with you, what help do you need, it's what can you do and how could some support enable you to carry on doing that for longer. And we're finding that there's a very clear correlation that the longer people are able to maintain their independence and they have choice and control over their lives, the healthier they stay and actually the more able to live an independent life they're able to do. And we're doing some very interesting work at the moment with people with a learning disability to see do we really, can we use this different approach to really understand where people are and what their needs are and what their strengths are so that they can have a more independent life, which does tend to be cheaper as well as being a better outcome for them. And then finally, we're looking to work very closely with the NHS. The prevention agenda means we have to be more effective working with community services. There's been one of the real issues over the last several years that the NHS has increasingly been focusing on hospital services. The vast majority of the NHS budget is spent on hospital services. Actually, the vast majority of interventions with people that keep them well happen in the community, so we need to be working there. But then we're also working very closely with the hospital system so that when people have been in hospital, we can get them out the moment that they no longer need hospital care and get them back home, back into the community. People recover much more quickly. So not only do we reduce the pressure on the NHS system, we're actually getting people a better quality of life and a better experience, and actually that they will recover more rapidly. So we're very much focusing therefore in terms of the workforce. Can we get the right workforce with the right skills and the right philosophy and the right approach? We're looking at informal unpaid carers because they make a tremendous difference to people's lives, and we're looking to see where we can make better use of technology so that we can draw on all of the latest advances so that people can use technology to maintain themselves independently at home rather than needing someone to come in to provide personal care. So it's a slightly long-winded answer to your question, but hopefully it's given some pointers as to where we're focusing.
Thank you for that. Well, Councillor Mike Clark. Oh. Rob. Right, so Rob's first then. Mike, do you actually want to speak, or just highlighting that Rob wants to speak? Right, Rob.
Yeah, thanks, Chairman. I was just interested if I could have a bit more information about the Section 117 aftercare issue. Am I assuming rightly that this is for people who are older adults who are being sectioned, or is this everyone? Wow. Because that's obviously a regular occurrence. I take it the modelling for the figure that you've come up with is based on data from LPFT in terms of the number of people having sectioned to an ordinary resident?
No, so the modelling that we've got is for all our clients within our adult social care area. The financial cost that we've incurred in 23-24 is actually on other local authorities being able to apply the ruling and, for want of a better phrase, bill us. So that's what the 454,000 is. That's just one person. So what we're going through is just working client by client with our heads of service across all of our areas to see where the risks are that we know about. But obviously, I mean, this person in particular left us a long, long time ago. So, yeah, we will do our best to mitigate where we can, but it applies to everybody, wherever they may be in the country.
Just on that, do we have many that are coming in from outside Lincolnshire that, in effect, we're swallowing up their health costs on that then, or not? We don't have many incomers for that service. No. The other thing is, on the S117, is the agreement, our sort of contract with the LPFT, in effect aligned to address this issue?
Do you want to? Yeah, so at the moment we're working through what the risks are that we face, because it is a brand new ruling that we need to go through. There isn't anything that you can align because it is a ruling. So what we basically need to work through is who are the people that we've got in receipt of our care that is sort of applicable under this new ruling. Likewise, that's what every other local authority is doing. And then the outcome of that work, which we'll be concluding with our ADs and their heads of service in the coming weeks, will then have to have an impact analysis on obviously from the clinical perspective, but also from the financial perspective.
So just to be clear, because if somebody is sectioned, technically then they would go into an LPFT home or hospital, or not, they would be at home.
Not necessarily. They would, if sectioned, then they would go into a mental health inpatient care, but that might not necessarily be LPFT. Could be an out of area placement as well.
Yeah, but that's what I'm asking. If there's a lot of people from outside Lincolnshire coming in to use our services being referred in, do we have additional costs there, or they could be at home? I mean, i.e., if they went into, let's say they went in-house to whether it was Scunthorpe or whether it was at Lincoln on LPFT, and they've got a social care element now which we're expected to pay, correct? Would they, therefore, in theory, LPFT's got them in-house and paying, so are they then recharging us? I'm struggling to get...
So the section 117 is aftercare. So it relates to when people are discharged from mental health inpatient care and they're then receiving ongoing support in the community. So it's the ICB and LCC who have to meet that.
And so are they sectioned before, or is the section actually the sectioned, then they go in-house, and then we're looking at the bit when they are coming out of that service?
So section 117 it's section 117 of the Mental Health Act, which entitles people to aftercare on discharge, and we have to share the cost of that between LCC and LPFT, depending on which section of the mental health the person was detained on. So it's not necessarily all sections, it's particular sections of the Mental Health Act.
Yes, so dementia wouldn't fall into the category.
I think it's predominantly section 3 and section 2, I think, in terms of the aftercare entitlement, but I'd need to double check on that.
And the other element then is, so if they're coming out, well, I'll let Martin answer first.
Yeah, just to pick up one thing, and I think the ordinary residence point is a key thing here. So, if I'm understanding correctly what you're suggesting, so if there were a person living in another part of the country who was sectioned and they were moved for their care into the county, and then having completed their care, they were then discharged and had an entitlement to care under section 117. They wouldn't be the responsibility of Lincolnshire, because they were only in Lincolnshire because the system had moved them there. So if they were, if you said from Scunthorpe, then that would still be their home local authority and they would be responsible. However, if there's a Lincolnshire person who gets sectioned and the NHS move them to Northamptonshire for their treatment, at the point where they're discharged, then it's still Lincolnshire that's responsible for them, even if they're in Northamptonshire, because it was the care system that put them in Northamptonshire. They didn't choose to go there. So it's based on where they were living at the point where they were sectioned.
And there's no means testing?
No, it's a statutory entitlement to free care, free aftercare, paid for by the public purse.
And how long does that carry on for?
As long as the care is required.
As long as they need care? Mm. And generally, how long, have we got any formal figures on that?
Pretty much for entirety, yeah. I mean, there are reviews, but very few of the reviews end up with no longer care being needed. So yeah,
so in effect, it's about one of the only services that really has no end game and no means test.
But it does help to prevent readmission. So therefore, in terms of the overall public purse, it is it does help to prevent, you know, escalation of need, but also really high cost mental health inpatient provision. So,
and I think realistically, to a large extent, the people who are subject to this, if they were subject to a means test, I don't think we'd be getting very much income from them anyway. So the net effect may not be that great. It's a question of which organisation is responsible for funding it. But yes, my instinct would be that if we were to means test people, there wouldn't be a great deal of income, and therefore the net financial implication isn't very great. It's a question of who pays, though, that does make a difference.
An LPFT would still have an input in that patient's well-being or not? Or
So-
technically they're discharged at that point from LPFT and
Yeah.
back into our hands?
well, it's, I mean, Section 117 aftercare is in the care in the community. So, but we
Right.
split that care obligation with the ICB.
Yeah.
So, yeah, LPFT won't be the deliverer of services. It's more likely to be, you know, adult social care providers and sort of more community-based health providers. So, but we do have a Section 117 policy that we've developed jointly with the ICB and LPFT, and that sort of sets out our respective obligations as organisations and who pays what.
Okay, it's clear. I think it just sort of makes it, yeah. Just I think sometimes you read into it and it just unravels it better, so makes it clearer. And the only other thing would be, well, the long-term self-funders, that is quite a high number that are coming off being self-funders where they actually are now requiring LCC support. Have we got a predicted tool on that going forward then? Because that's quite a high number now that are coming. What's the future? Can we do we have like a predictive model for like 5-10 years, knowing what's coming or the potential?
We did do a model when the adult social care reforms were being discussed, and it was the national modelling that we used that showed us potentially how many self-funders we have compared to local authority funders. And if you remember when we went through the COVID-19 grant funding, which covered all people in receipt of adult social care, we also checked that modelling against the work we did as part of the COVID-19 funding, which confirmed the modelling for us was pretty accurate. That will need updating. So I think for me, one of the focuses for 24-25 as we go into the new round for setting fee rates and what we need to do to support and shape the market going forward for the next round of commercial contracts and service requirements will be a review of the self-funders. Because obviously we've had that cost of living crisis, we've had the national living wage increase, we've got our rates set. It's that delicate balance that we go through every year at the moment, which says, are we setting our rates accordingly? That means actually the way that the self-funders are paying it aren't excessively. An increase isn't seen as excessive in that area. It's a delicate balance we've got to work with our market on year in, year out. And I would suggest that next focus is in readiness for the work that we'll be doing for the next 25-26 modelling.
Yeah, because I think that's quite important feeding into the medium long-term plan, because that'll be really where we're going to get quite high budget cost pressures, I suppose, going forward. And you've got your Better Care Fund submission ready then?
Yes, yeah, we're on target for that. It's not a full submission, so it's just an update. So we already submitted the 24-26 last year. The submission, which is due on Monday, is an update to that plan for finance, for capacity and the quality matrix based on, from a financial perspective, any of the changes. So for example, for us, the confirmation of the discharge funding that was received as part of the settlement will be within that. For across Lincolnshire, the update on the capacity expectations versus the demand, and then the performance metrics. So yeah, that's in draft at the moment.
Brilliant, thank you. And the only other thing is, in some sense, I agree with all your preventions and the maintaining independence and NHS community service. in fact, a lot of that is what we're looking at, which should all come together quite nicely over the next period. And the next, our next committee meeting, actually, we've got coming back the Public Health, in effect, annual report, which is what it's all about, technically, like you said, Martin, prevention, in effect, getting the residents of Lincolnshire in shape for retirement, which is crucial to reduce the issues coming forward. So, brilliant. Thank you very much for that. I think, yeah, credit due, all in order, all good financial accounting and being realistic and getting the budget and making sure we're on target. Mike.
Thank you, Chairman. I was interested in reading the section on grant funding on page 13, where we mentioned the Ukraine system. I note that we've had 227 guests arrive. It says in the UK. How many of those actually come into the county, and how many have left? Has there been a balance through the period? And I know we have sometimes had adverse press about the added work that it gives to the system in accommodating Ukraine families. Have we experienced any of that within the county? Thank you.
So sorry, that should be 227 in Lincolnshire.uk, coming UK, so it's 227 that have come into Lincolnshire. Very few leavers, but I'll check those. I think it's less than 10, but we've had very few leavers, and any costs incurred regardless of where those costs are. So for example, if it's district councils, if it's support we've put in through charities and voluntary organisations, that is from a financial perspective fully funded through the grant income that we have received. So there is no financial implication to any individual, any family or provider as a result of that.
Okay. All right. Well, thank you very much, Pam.
Thank you very much. Thank you for your kind words, and it's been a joy. So thank you.
Thank you. So we'll move on to the Care Quality Commission Improvement Plan and, in effect, the reports from the CQC inspection. So I think you're taking on this one, Martin.
Okay, thank you. So as members of the committee will be well aware, Lincolnshire County Council was the first council in the country to go through the CQC assurance process. We went through that process near enough a year ago now, with the final report being published in November. Worth noting that CQC has only very recently published the first 3 reports from the substantive assurance process. So they did 5 pilots. They've now published 3 of the proper reports. Of the 8 that have been published so far, 7 receive a good rating. Only 1 has received a requires improvement rating. It's worth noting that although Lincolnshire came out with the best, if you add all the sub-elements together, Lincolnshire came out with the best results from the pilots. I'm afraid that Hertfordshire has now come out with a better report from the substantive process. They got 1 outstanding. All of the other areas were good. So the report that CQC gave us identified a number of areas for improvement. We previously brought to you a sort of set of appendices which identify each of those areas for improvement and what we are doing, what they are and what we're doing about them and what we're seeking to achieve. What we've provided this time is an update on each of those, and then Appendix H. We've set out the various actions that we're taking, and we've set that out in a table to just make it a little bit easier for you to see what we're doing. And just worth noting that as part of that work, we've been looking again at the adult social care vision. It's become clear that there's been quite a few sort of different approaches, different visions, different perspectives, and we're doing some work to try to bring things together so we have a really a simple and memorable but meaningful statement about what it is that we're seeking to achieve, and that's set out at the bottom of page 16. So I think the key point is that the work to address the areas for improvement that were identified by the CQC are that work is proceeding, and we're making good progress. We're also now starting to get ready for when they come back. CQC have been instructed by government that they should do the entire country over a period of 2 years. So they did us about a year ago. So in principle, they should come back in a year to 18 months or so. What I'm doing with the team is making sure that we are ready, so that we have the material, we have the self-awareness, that sense of where we are as an organisation. That's all ready, so that rather than there being a mad rush at the point where the phone call comes, that we are ready to go at whenever time that call might come. Because I've been saying, well, we would expect them to come in a year to 18 months or so when they've done everyone else. It is entirely possible that CQC might take the view that the five local authorities that were the pilots, because the process that they're doing now is really quite significantly different from the process they used with us, because they've learnt from the pilots. It is entirely possible that CQC might say, well, actually, we're going to go back to one or more of the pilots and try the substantive process with them now, on the basis that it's different from the pilot process. So we need to be ready, and so we're making sure that we are organised for that. And then one last thing, just a point that has come up, and it's sort of opportune given that we've just had the discussion about the financial position. The first page of the CQC report itself, so Appendix G, that starts on page 31. That sets out some demographic figures and some financial facts from CQC. And I should note that these figures are figures presented by the CQC, not figures that were given to us. And they are, I think you would note that actually those figures are somewhat different from the figures that we were presenting to you earlier, or that you will recognise. And indeed, the figure for the population of the county is different. And just to provide a little bit of explanation, these figures, the CQC was instructed by DHSC and DLUC that they should present this data to provide some context. It's taken from a national data set that is calculated in a particular way. It's not the way that I think any local authority in the country actually presents its own data. One thing that I think is particularly important to highlight that could very easily be misinterpreted. So if you look at the second, the first and second bullet points, so it says that in 2022-3 we estimated that our total budget for the council would be 895 million, and we actually spent 917 as a whole council, 22 million more than estimated, and that we would spend 230 million on adult social care, and we actually spent 234 million, so 4 million more than estimated. It would be very easy when looking at those figures to interpret that as meaning that the council overspent. That would be an incorrect assumption. In many cases, what happened was that the government gave us additional funding during the course of the year and asked us to spend it, some of that on social care, some of it on other things. Clearly, we couldn't build that into our budgets at the start of the year because we didn't know the government was going to give it to us. So they're saying, this is what you said you were going to spend, this is what you actually spent. Giving an implication that that's poor financial management. In fact, it was that the government gave us significant amounts of additional funding, asked us to spend it, and we did, and therefore we spent significantly more than we had thought we were going to spend, but that wasn't an overspend. So just for that clarification. But thank you.
Excellent. Thank you very much. Wendy?
Thank you, and thank you for that, Martin. CQC, I still get very upset about it because we were the first, obviously, on the list of people they visited, and I quite frankly and quite openly say to whoever asked me, they weren't up to the job, they didn't know, they hadn't gelled, they didn't know what they were doing really. Now they are, and as Martin said, you know, we are getting ready for them to come back, and I welcome them to come back, because the score of good is not what we do. We are an excellent council, and to be rated good alongside the other 5 that was, well, there was one that was inadequate, but we had the highest score and we did deserve a better than good. But we have to go with what we've got, so I welcome them to come back, and we will be ready for them, and we will be getting an excellent, else heads will roll.
Thank you. Colin?
Probably be outstanding rather than excellent. That's all right. So you can't take the inspector out of the job. I'm interested in the adult safeguarding, and I'm interested in the story behind the adult safeguarding report, because it sounds as though we're doing our job in adult safeguarding correctly, but we're being criticised for partner organisations using different criteria to us, and then we've written to them and told them this is what we mean by this. I just don't quite understand the story there.
If I start, and then Justin may pick up some of the details. So we are in a position where safeguarding is everyone's business. So by law, the police and the NHS and the local authority, we all have equal responsibility for safeguarding. It just happens that the safeguarding inquiries are undertaken by the local authority, but all organisations have a responsibility to identify safeguarding issues and to make referrals. What we're finding is that a very substantial proportion of the referrals that are made to us do not meet the standard for a further inquiry to be undertaken. And of course, it takes quite a lot of time and effort to go through large numbers of referrals that then don't meet the standard. So we've been working with partners to say, well, can we ensure that all of our staff, because of course we have to be just as careful that the council's own staff are judging these things correctly, that we are really clear about when a safeguarding referral is appropriate, and that we're not using it when actually we've got a request for service, or if we think there's an issue with the quality of service, because quality of service is different from safeguarding, that we are using these systems appropriately. So we've been working with the partners, and so I did write to the chief executives of our various partner organisations about, well, you know, we've got this issue, we need to work together. Let's work together on this. And it was very encouraging that most of the organisations that I wrote to, I then got a very polite letter back saying, oh, you know, we really, this is clearly an important issue. Can we look at more detail of the data for referrals from our organisations so that we can see, you know, where are we, how are we performing? Are we getting things? Are we getting the thresholds wrong? Is there a training need for our staff? And a really sort of positive view about, you know, we need to get this right. We need to get the different organisations doing the right thing, because when I say safeguarding is everyone's business, it's not just looking out for it and then getting somebody else to do something about it. It is the responsibility of the organisation that spots it. Often they have a responsibility to seek to address the safeguarding issue themselves. So we've had a very positive reaction from almost all of the partners. We have, there is one organisation that has been less positive, and they work on a regional basis, and I've been engaging with colleagues in councils across the region, and they all have the same issue with this particular organisation. And they've essentially taken the stance, partly based on feedback they had from a CQC inspection, that more is better. And so they've been working on the basis that they've been training their staff that if you have any thought whatsoever that this might possibly be related to safeguarding, put in a safeguarding referral, because you can't possibly be wrong in that situation. And we are having, on a regional basis, conversations with that organisation to say, well, actually, that's not terribly helpful. I'm reminded of a colleague I worked with some years ago when he was talking about safeguarding issues. He said, when you're looking for a needle in a haystack, generally, the first thing you do is you don't make the haystack bigger. And that's the risk that we're doing, that we're making the haystack bigger, but there's still only one needle in it. And so the risk is that we'll actually miss some of the genuine safeguarding issues. So we are working with partners, and we are working with partners locally, and I think we're getting a very positive response, and working regionally with this other organisation and seeking to make progress with them. But it's a more complex situation with them because they are a regional organisation. So I hope that gives some clarity. Justin, I don't know if there was anything you wanted to add to that.
Thanks, Martin. Yeah, so I think the other thing that we're going to be doing this year is actually revisiting the front-end referral process. So I think a lot of partners send us things because they think it'll be helpful. And, you know, if we can actually separate that out into intelligence and actually then progress legitimate concerns through to the safeguarding team, so that we're not overwhelming them through triage and they can focus on that work, then that's going to be helpful. So we have got some support from the County Council's corporate transformation team that are going to help us revisit how concerns and referrals are made to us, and then how we can actually manage those in a different way. So that should help sort of, to some extent, be able to, you know, separate intelligence from true safeguarding concerns going forward. We will, of course, with the LSAB, continue to do the wider work around making safeguarding personal, because as Martin says, you know, it's an obligation on all partners to keep people safe. So we'll be doing that at the same time.
Yeah, Colin.
In the document, it says that between April and October, there were 1,400 additional concerns. So if we extrapolate that to a year, that means nearly 3,000 additional concerns in the year. A, is that continuing? And B, is our triaging of those concerns, where we push some back, putting anybody at risk because the organisation that's made the recommendation believes they've transferred the problem?
So the answer is yes. The number of concerns that are being raised continues to increase, and that does cause some operational problems for us because we're having to triage every single one. So, you know, but we're having to look at the resources in the team, but we see the review of the front door process as being the solution. But in terms of risk, the fact that we triage every single one in a timely way, that actually, you know, people aren't being put at risk. And I think the other thing I'll say is that, you know, in terms of our wider performance indicator for our safeguarding function, they're still all on target. So the team are soaking up all this additional work, but still keeping people safe. So I need to reassure on that. But yeah, the volume issue is a challenge for us. So we need to continue to work with partners to resolve that.
That's the bit that really, it's this making sure that what's coming through is tidied up and tightened up, isn't it? It's certainly a piece of work there to stop that high numbers coming through just because people are basically pinging them on to us and not actually doing a bit further research. And I think some of that is, you know what, sometimes actually just make a quick chat about it all. I think it's, you know, if you don't watch it, you're panicking and blocking the whole system up, and then we don't really get to the people that we want to be getting to because we're blocking the system.
Sorry, I absolutely get all of that, and I can see that we're doing very well here. What I'm concerned about is if 3,000 have been put forward, 1,000 have been accepted as genuine safeguarding issues, 2,000 have been pushed back to these organisations. Are any of those 2,000 at risk? They're not directly our responsibility, but is there a vacuum that they're being pushed back into? The organisation will then pick it up and deal with it as it's a flat tyre, or it's a leaking roof, or they will know what it is and deal with it.
Yeah, so I mean, the concerns that are sent to us that don't meet the criteria for Section 42, that the majority are really, really low-level issues. So it might be Mr. Miggins bumps into Mrs. Smith in a care home and knocks a biscuit out of her hand. and the care home reported to us as a safeguarding incident. So in those sort of concerns, there is no need for any follow-up action. Yeah, you know, if someone's at significant risk of harm, then it will meet the criteria, and we'd do an inquiry and make sure people are safe. So, and we do periodically do quality audits of the triaging and of the no further action concerns we close down, and that audit work is always reassuring that the right decision's being made.
Okay. I mean, I think when you sort of look at this whole report and the actions, in some sense, I think it summarises it up pretty well at the very beginning, which talks that the CQC method of inspecting us is changing. It's already changed. We need to keep in contact with the changes, because when they next come back, it will not be like it was the first time that they came to inspect us, and their focus will change. But in essence, we still need to take on board what they have raised and resolve some of these issues, so that when they come back, we can say we have listened and we have adapted. And things like financial assessments, I can't stress enough how quick that process needs to be. I think the quicker people know where they are and what they're entitled to, the better. And so, you know, I fully support that. And I think we've mentioned home care surveys before, that, you know, if we provide a service, we shouldn't. One of the criteria is you give us feedback instantly at the end of it, and so that process helps us to keep evolving, because, you know, remember, we are a commissioning council, so it does mean we get flexibility to adapt and change to what people's needs are. Most of all the other bits actually are already in, well, in fact, most things are in the system to be fine-tuned and made better and improved on. So all in all, we're going in the right direction, and I think we'll see what happens when they next come back and change. The other thing just to note in here is the new vision of adult social care, which I will make reference to, that we all want to live in the place we call home, with the people and things that we love, in communities where we look out for one another, doing what matters to us. So that is that now is that actually official now, that that's our new, or is that still being tinkered with?
I think we're still going through the process.
Right. I would slip one word in there, because we all want to live well. I think that's the half of the priority of what we're really after, and the only thing I would perhaps put in there is a bit about prevention, because we know that is absolutely crucial. The nation has to get itself fitter and healthier, and there's no need to sort of be putting up with a lot of sort of some of the issues, when we can in effect take responsibility and get ourselves sort of geared up for retirement, really, or the best shape we can. Mike.
Thank you, Chairman. It was quite an eye-opener reading all the information that's been given to us in this report. A couple of observations, if I may. It would be, I think, be useful for fellow councillors and any member of the public that would read this report to have some idea of the numbers that we're dealing with, because obviously we're spending a large amount of public money, and I think it would be wrong not to, as it were, blow our own trumpet as the number of people that we're dealing with and caring for, because I think that's a big item. And in Annex C, I was wondering, it mentions new digital technologies. I wondered how far down the line we were going with that idea in order to help us run a bit more enthusiastically or more better for the clients. And similarly in Annex G, I was wondering, we have been told before about apprenticeships and how useful that's been, but have we any idea at the moment how many are under training that will help us in the future. Thank you very much.
If I pick up, and then I may ask Justin to come on a couple of things. So very much take your point about the value of the sort of context, the wider context. Some years ago, there was a tradition that local authorities and adult social care departments would publish a local account about what had been done over the past year, and which would give a sense of the numbers of people supported. That's sort of rather fallen out of fashion in recent years. We're looking at whether we could do something like that again, something short and accessible, but that just gives you an overview of, as you say, we're spending a very large amount of money. Who are we spending it on, and what are we getting from that? So we're working on that. In terms of digital, we've just been in the process of completing some work with a consultancy called Channel 3 to help us to work through where we can get most benefit from the digital revolution that's been happening, and really their guidance has been particularly that there's an awful lot more that could be done when people are first starting to find it a bit difficult to manage at home. That actually at that stage, pointing people towards the technology that is available, and there's a huge amount of consumer electronics that is available to people, that giving people a bit of guidance as to how they can access that, what might be appropriate, what might be available, that can make a big difference to people's lives, people's ability to maintain their independence. So they're advising that we go down that route. They're also advising that we make much more use of remote sensing. So you'll be aware, lots of people now have those those front doorbells that have a camera and a link to your phone. That kind of technology is readily available and is quite easily and fairly cheaply installable in people's houses. So you can have cameras and motion sensors and the like in someone's home, which can all be wired up both to connect to family members' phones, so we don't need to go through a formal service process. People's friends and families can keep an eye on them. The latest development, which is I think particularly exciting, is that through AI, the system can learn what someone's habits are, and so rather than having to have someone monitoring and saying, well, have they switched the kettle on, have they gone to the loo, have they moved, the system can do that, and then it can send an alert if someone's behaviour is well out of the norm. And the parallel that I came across a few years ago was in care homes. Quite often, they will do checks during the night, and often, every couple of hours, they'll go around each of the rooms. Now, just a member of staff poke their head through the door just to check that the person in bed is sleeping fine and is okay. Apart from the fact that that's really disturbing for the individual, I'm not sure how many of us would like to have someone poking their head around the door every couple of hours during the night while we were trying to sleep. It's disturbing for the individual. It's also expensive because you've got to have staff awake walking around the building doing this. Technology is available, and I've seen it installed in a number of homes, which is sound activated recording, so that if there is a sudden noise in the room, it records it and sends a audio file by email to the reception desk, and it pings up, and the person sat on reception can listen to what's the noise that's just happened in that room, and they can then make a judgment as to whether something has happened, or it was just Mrs. Miggins was turning over a bit noisily in bed and is fine. And that gives you a huge advantage that you can respond much more quickly, because you'll respond, there and then, whereas they might have fallen out of bed and you not do the round for another hour or so. But it also means that you're not disturbing the individual and you're not having to employ a member of staff to walk around. That kind of AI, that kind of technology is much more readily available now through consumer electronics, that people can use that at home quite cheaply, that can give that level of reassurance that they don't actually need to call on adult social care at all, but they might just get some help from us in the first place about working out what it is to buy. So that's the kind of thing that we can do with the technology. I mean, there's an awful lot more, but it's the consultants saying that would be an area where we could make a big difference to people's lives, and it would save the council a significant amount of money.
It's quite interesting, really, the digital, isn't it? Because there will become a point when it becomes invasive into your own private life. How far do we go with the point? If you've got cameras and everything else in your house, keeping an eye on you, then in effect it's quite interesting concept. But one of the things that when I travel about is if we don't watch it, we're becoming so reliant on digital that actually we're losing all form of social contact, and the only thing that you'll ever do is you'll go into your home and you'll be digitally looked after, and actually no one will visit you. But anyway, Mike?
Yeah, I can see the digital being very useful in rural areas where obviously getting to people would be a concern and very timely and costly that way. Could I have an answer to the question about apprenticeships? Thank you.
You're right, I forgot that one, and I don't know the answer. I don't know if Justin, do you know the answer?
Sorry, in terms of how many apprentices do we have, was the question, sorry.
I noticed it said that there was apprenticeships, and I was wondering how many we've now got in the system, because we were told a few months or even last year, how well the system was working, and the fact that we'd managed to get, I think it was 11 nurses into working at the hospital. And I'm wondering what sort of progress we were now making through the medical school. Thank you.
Yeah, so I'm sorry, I don't have numbers. We can follow that up and get some for you, though. Yeah, we have got apprentices opportunities in a number of different areas, including day opportunities. We're progressing them within social work services as well. So we can get some intelligence on that for you.
Just remember though, the council in itself is the commissioner, so we do have a number of apprenticeships within the council, and I have a feeling something like 12 or something that we've just taken on last year, but I mean, don't quote me on that, but across the board that is. But actually, and I suppose the workforce, there will be an agenda item at some point coming up soon, maybe on the workforce, which actually would be where that wants reflecting back to as an industry-wide for Lincolnshire, what is the apprenticeship recruitment process, because obviously workforce is such a key element to making sure we've got good services. Wendy?
Yeah, I was talking to Chris Erskine yesterday, our head social worker, and they've just had a few apprenticeships qualify again, and certainly with Andrea Kingdom's team in the hospitals, again, they've just had a number of apprentice OTs qualify and just taken on again. So yeah, it would be interesting to get the numbers of all the departments of what apprenticeships have just qualified and how many we've taken on again, because it is I think it's quite a substantial number.
Just on that, is the university's medical school or department, whatever it's called, that must be in full flow now, and are we seeing any, that should actually be feeding through and into the system as well?
So the medical school is fully up and running. I suppose the issue is, of course, they're training people for the NHS rather than for adult social care. Is
there any sort of way we can capitalise on anything in that area or not?
Well, we're certainly working closely with the university to identify the scope for developments in the social care field. But yes, their area is more medical and healthcare than social care. But we do have links with them.
Okay. Any other questions? So, all right. Well, it's nice to see. I think the end of the report really summarised everything up in the actions. So. And I think it'll be one of those that be worth just coming back at some point just to make sure that we're all ready for the next time that they come, and just see where we are in terms of an update on the progress, because most of it should be signed off soon in some form or another. over time, but we can slot that in or just have an update some point with the work programme going forward. Which then takes us on to the work programme. I think got enough comments noted on that previous item. So Simon, work programme, please.
Thank you, Chairman. Just referring members of the committee to pages 58 and 59, just to say that there are no confirmed changes to the list of items from 24th of July onwards. I do note the Chairman's comment, though, because there is an item on the sort of to-be programme list in relation to workforce development, recruitment and retention. So that is something we can look at, and maybe I can, in terms of the previous item on the CQC improvement, we can look at perhaps, I don't know whether Martin wants to suggest whether that would be another 6 months or 9 months or a year, perhaps 9 months, perhaps in March 25. Thank you, Chairman.
Well, that'll give everybody time, whoever's in power and everyone else, to have had their party conferences and all discuss what they're going to do for adult social care to feed into that, because workforce will be a big part. Right, well, that's done. That's finished in record time for adults. So thank you all for coming. Thank you.